mentioned, today we actually have with us two seasoned home experts who will be helping drive a lot of things home for us in our session. And I'm very hopeful that as previous sessions we've always had, somebody comes back to tell us what they have learned and what they've actually been able to go back to do in their facility. I'm sure that there's going to be a lot of learning from our sessions today. And it's an honor to introduce to us these seasoned experts. And so on the list is Dr. Amma Boadu. She is a specialist psychiatrist, and she's actually the Deputy Director Mental Health for the Ghana Health Service. She has in the last 3 years been working to minimize the mental health treatment gap by leading the development of training programs and also training both mental health and non-mental health practitioners pre and in service. She also continues to lead in developing training programs, and also she leads facilitators for mental health and psychosocial support skills training for different categories of emergency respondents, apart from health workers across the country, to address the ever-growing need for psychosocial support, which is almost always forgotten in emergency situations, such as COVID pandemic and outbreak of diseases such as VHFs and other emergency situations. Prior to her role in the Ghana Health Service, she has been providing specialist psychiatrist care to people with lived experience in underserved areas of Ghana through her work with an NGO called Basic Needs Ghana, apart from providing services in different capacities at the Accra Psychiatric Hospital for 7 years. She is a member of the Ghana College of Physicians and Surgeons, and she's also pursuing a fellowship in psychiatry in the same college. A warm welcome to you, Dr. Amma Boadu. DJ, next slide, please. Thank you. So our next expert on our list for today is Dr. Adwoa Kusi-Kyere. She's also a psychiatrist and a medical educator with extensive experience in mental health service delivery. She is a member of both the Ghana College of Physicians and Surgeons and the West African College of Physicians. And she plays an important role in training and mentoring psychiatric genius residents. She also trains medical and physician assistant students and provide guidance and support to primary care professionals and mental health nurses to recognize, evaluate, and manage prevalent mental, neurological, and substance use disorders. Dr. Kusi-Kyere currently works at the Mental Health Department of the Ghana Health Service Institutional Care Division, where she helps to coordinate, monitor, and develop mental health services in both facility and community-based settings in Ghana. A very warm welcome to you, Doug. DJ, next slide. So at this juncture, I would want to hand over to Dr. Amma Boadu to kind of take us through depression in various age groups and subpopulation. Thank you so much, and over to you. Dr. Amma. Hello, Doc. Are you able to hear us?
Yes, I can hear you.
Right. Thank you so much. Over to you at this point.
Okay. Thank you very much. And good afternoon to all our listeners and everybody that has joined us. It's indeed a pleasure for all of us to be discussing depression, which is a very common mental health disorder, especially for those of us in primary health care. And so this afternoon, we are privileged to be leading the discussion. We believe that there's a lot that we'll be able to learn from this discussion to help us provide better services. Thank you very much. Next slide, please. Next slide, please. So this is going to be the outline of our presentation. A bit of introduction. We would see how we'd be able to identify depression in different populations as we meet them. And then we'll do a suicide risk assessment and then conclude. Next, please. So when we talk about depression, it is very common, and we've heard people talk about the fact that they are depressed and all that. But people have various meanings when they talk about depression. It is also very common to feel sad when we are going through some circumstances in our lives. But when we talk about depression, there is a criteria for depression. So depression is a very common mental health disorder. It's actually one of the mood disorders. And we talk about a mental disorder when the symptoms persist and then affects one's functionality. So depression, as I did mention, affects how an individual feels, our emotions. So there's persistent feeling of feeling sad. There's a loss of energy where people feel very tired. And the last core symptom is what we refer to as anhedonia, where they lose interest, or there's a decrease in interest or the pleasure they derive in activities that prior to their current circumstance, had a lot of pleasure from. And depression would affect how an individual feels and how he or he thinks, and certainly affects the way the person behaves. Apart from the emotional symptoms, there could also be some physical impairments and in functioning, as I had mentioned. Next slide, please. So why do we have to talk about depression? Thank you. Why do we have to talk about depression in the different populations or subgroupings in the society? This is so because the presentations of depression, the experiences of depression are very different for people depending on certain characteristics. So their age, their cultural background, religious backgrounds, and all that. So it's very important that we're able to have a high index of suspicion and therefore look out for depression actively. So we'll be able to pick them up early and intervene. Next slide, please. So in primary health care, usually we are talking about people accessing health within a short distance where they live, so they don't have to travel a very long distance. So they are within the people within the community. And on the average, it's been found that about 5% of people in the population at any point in time have diagnosable or clinical depression. For those of us in primary health care, it's also been found out that as many as 10 to 20% of the people that we see on OPD basis and then our inpatients have some degree of clinical depression, which is quite worrying if we are not able to pick depression, and then also put in some interventions to improve the mental status and then even the physical health of the individuals, because depression has an impact on the outcome of the physical conditions that people come into the facilities with. And then apart from it having an impact on the outcome of the physical conditions, depression is also known to be a predisposing factor to people developing other physical conditions. So for instance, it's been found out that people that are depressed have a risk factor of developing myocardial infarctions. So when we talk about broken hearts, as we commonly call depression in the community, it is not just a mere saying, but it does have an impact. Looking at the stress response, so there's a release of stress hormones, cortisol, and then all the physiological impacts that all these have on an individual. So there's reduced oxygen to our heart cells. And then when these things go on, then people develop myocardial ischemia or myocardial infarction. So indeed, it's very important that we in primary healthcare are able to identify depression and manage appropriately. Next slide, please. Next slide. So how do we make a diagnosis for depression? With the clinical diagnosis of depression, we have what we refer to as the core symptoms of depression, and then there are the other symptoms of depression. For an individual to accurately make a diagnosis of depression, clinical depression, I mean, the patient or the individual before you should be experiencing at least 2 of the core symptoms, and then 3 or more of the other symptoms. And these should have been going on for at least 2 weeks and should impair or may not impair the individual's functionalities. So for instance, it is very normal for me to feel sad when I lose a loved one, yes, but I will get over it anyway. It is very normal for people to have some of these experiences as part of life. But when these experiences, persist for over 2 weeks, then we should be thinking of depression. So what are the core symptoms? There are basically 3. So the individual talks about the fact that he or she has a low mood or feels very sad. They have, a loss of interest, or there's a reduction in pleasure in activities that they used to derive a lot of pleasure from. And they have what we refer to as low fatigue. They have low energy or a lack of motivation. So these things should have been going on for at least 2 weeks. So those are the 3 core symptoms of depression. Then there are other symptoms, such as the individual having difficulty concentrating. They are irritable, they become angry easily. Sometimes they have withdrawal from their friends and all that. People have problems with sleep. The problem with sleep could be that they are either sleeping excessively or sleeping very little. People also have, changes in the appetite, as in, for some people, they would eat a lot others would also eat very, very little. Therefore, if you have an individual that is sleeping excessively and eating excessively, certainly that person is going to have a change in weight. People also have low self-esteem or self-confidence. Then there's have a sense of hopelessness or worthlessness. So they think that their life would amount to nothing. They see nothing good about themselves. Life is all so bleak and all. So when you have some of these symptoms, in addition to the core symptoms, and these have been persisting for 2 weeks or more, then we talk about clinical depression. Let's go on. So in primary health care, there's a very common tool that we can use to screen for depression, actually make a diagnosis of depression, and then monitor our progress as we manage the individual. And this is referred to as the PHQ-9 questionnaire. It's actually a 9-item questionnaire, very simple, and the questions are based on the individual's experiences in the last 2 weeks that he or she is actually administering this questionnaire. So the questions are essentially the signs and symptoms for depression, and the score is from 0 to a maximum of 27. So we look at the individual questions and then put a score to it, depending on how long this particular symptom has been happening or the individual has been experiencing that particular symptom, and then we score. So the first one is little interest or pleasure in doing things. So if the individual has no symptom as such, then you score a 0. If it's been going on for several days, then you score 1. If it's been going on for more than half of the days, that is 2. We are talking about 2 weeks. So if it's been going on for more than 7 days, then certainly that's more than half of the days, or for how long the individual has been experiencing it. And then if it's been going for almost every day, and there's the maximum score for 3. This is so because for some people, the symptoms are sort of fleeting or waxing and waning. So there are times that these symptoms are there, other times too, they are persistent. So depending on how they're experiencing, then we score. So it's the same scoring for all the questions. So the second is feeling down, depressed, or hopeless. 3, trouble falling asleep, staying asleep or sleeping excessively. Then feeling tired or having little energy. We talked about low energy or fatigue. There's the thing about sleep, poor appetite or overeating. Feeling bad about yourself, or that you're a failure or have let others or yourself down. Then trouble concentrating on things such as reading the newspaper or watching television. In our setting, this might not actually apply depending on the population we are dealing with. For instance, if you ask my grandmother this question, she certainly will not be able to give you an appropriate answer. But how we are able to still test for concentration for an individual? Are they able to follow through a conversation? Are they able to complete tasks? All these would help us to be able to know whether people are able to concentrate or not. Then the 8th question is about moving or speaking so slowly that other people could have noticed, or the opposite, that is being so fidgety or restless that you have been moving around a little more than usual. So in depression, sometimes people have psychomotor retardation or agitation. For some people, it slows them so much that you can actually tell in their physical activity, the way they walk, even the way they reason, and then they talk. So they talk slowly, they move slowly. Everything they do is, with reduced energy. In some other people, where there's agitation, you know, they tend to become fidgety, they are restless, they move about. When they sit, they are restless. You can see that they are moving their legs, their hands, and all that. So we need to look out for all these things. And then question 9 is very, very important because it's a single question that screens for suicidality. Once we have an individual answering or scoring a yes to this, we need to probe further or refer the individual. So how do we do the scoring of the PHQ-9? So if the individual has a score from 0 to 4, then we say that that person has no depression or very minimal, and therefore there is no intervention needed. If the person scores 5 to 9, we talk about the fact that the person has mild depression. For such an individual, we do what's referred to as watchful waiting. In watchful waiting, we would do a reassessment using the same screening tool for that individual on his or her next visit. For a person that scores between 10 and 14, we say that individual has moderate depression. For such an individual, we should be thinking about intervention. Intervention could be biological, psychological, and social. When you talk about the risk factors of depression, there are biological factors, social factors, psychological factors. So biological factors, for instance, the mere fact that I'm a female puts me at risk, at a higher risk of developing depression. So that's a biological factor. If I have a stroke, it's a biological factor. That puts me at a higher risk of developing depression. Then we talk about the psychosocial factors. So losses, bereavement, people have lost their jobs, difficulty in their relationships, difficulties at their workplaces and all that. So all these come together to affect an individual's mental health state, and especially we're talking about depression. So when we are doing the assessment, we look out for all these, and therefore an intervention should, address all these areas as well. So for somebody that scores moderate to severe, intervention would mean that you are either giving medications and adding on some psychosocial intervention. So you look for the psychosocial challenges affecting or impacting on that person's depression and address them. There is no point giving an individual so many medications to treat his or her depression when there are actually psychosocial factors. They will take the medications, all right, but if we don't address these conditions, they would persist and will not do very well. So it's important that we address the psychological and the social factors. Then a score of 19 means that that person has severe depression. And for this person, you would have to immediately put in some intervention and appropriately refer to a mental health professional to do further assessment. It's very, very important. And I've mentioned that an answer to the case of suicidality, that is the item 9, means that you should refer the individual for further assessment and intervention. We should never trivialize anything about suicidality. Next slide, please.
So hi, Doc. Just to draw our attention that we have 5 minutes more to go on this presentation. Thank you so much.
Yes, please. So why is it important for us to identify depression very early, and especially in primary health care? It's very important so that we can reduce the stigma that comes with mental illnesses, and especially for depression. In primary health care, we don't have to send people to the mental health corner, but rather whoever sits in the consulting room should be able to attend to people irrespective of whatever condition they come in. And therefore, we want people to get help in primary healthcare. It will reduce the stigma and discrimination and help people seek help early so that their outcomes are better. We also want to say that there are very effective and inexpensive medications or treatments for depression, and therefore nobody should suffer unduly. And a good outcome would impact on the individual's social, occupational, and other functionalities. And most importantly, early detection would help us prevent suicide. Next slide, please. Next. So I want to say that we should always have a high index of suspicion when we are seeing people of different age groups. Otherwise, we would miss, depression, because the presentations are very, very different, and sometimes they are very, very atypical. For instance, for children and adolescents, it's as common as it's estimated to be about 13% of adolescents experiencing depression, which is very, very, very high. And then for our children, about 3%. And most of the times we miss because we are not looking out for them. We don't have a high index of suspicion. The presentations, again, are very, very different. Children will present more with, physical symptoms. So they will commonly talk about the fact that they have, running stomachs, they have headaches and all the physical symptoms. They will not come with feeling sad, the fatigue, anhedonia and all. No, for children, it is a bit different. Then other problems that children would be difficulties or changes in their eating habits and then sleeping habits as well. So when we see these things, we should be thinking depression. Sometimes the academic performance will drop, because certainly if they are not able to concentrate in class, they won't be doing well. Our adolescents, would are more expressive, and so they will talk about the fact that they are feeling sad, they are no longer interested in the things around them. They talk about low self-esteem, they talk about worthlessness and all that. Next slide, please. For our children also, we would see that sometimes they are very tearful, or they will cry for no apparent reason. Sometimes they act out. They are very irritable. They have frequent outbursts of their tantrums. They would become withdrawn. So for a child that was very bubbly, very playful, rather we would see that there's this change where they play less, they are interacting less and all that. We've talked about changes in sleep and all. For children, rarely would they talk about or would they experience suicide or thoughts of death, but it still happens. So it's important that we are actively looking out for these. Next slide, please. In older adults, that is people above 60 years, depression is a bit difficult to diagnose, but it doesn't mean that it can't be diagnosed. Again, having a high index of suspicion, having the requisite skills and knowledge would help us make a diagnosis and intervene. The challenge with these people is the presentation of depression is very confusing and would appear as though these are just normal processes or experiences with old age. So we talked about forgetfulness, we talked about irritability and all that. So for our older adults, these are very common. For people with dementia, these are very, very, very common presentations, and sometimes there's a difficulty in differentiating between dementia and then depression in the older population, but we should be able to do that. There are so many risk factors where the elderly would experience depression. People lose their sense of independence. I mean, you can imagine for somebody who was doing very well, was taking care of himself and every other person, then suddenly, because of old age, being prone to the physical conditions that we are all aware with, so they lose their sense of independence and now have to depend on people. It is also a very known fact that old age can be very lonely, which is in itself a risk factor for depression. Then they also experience abuse, neglect, and all that. Next slide. Then there's another population that we want to look at: mothers pregnant, and then mothers or lactating mothers. It is very, very common to have postpartum depression in this group of people. Postpartum depression occurs in about 10% of women after they have delivered, and usually would happen a few weeks, a few months after they have delivered till about a year. And we know very well that for a child's development, you would need to have a mentally stable or mentally healthy mother or carer for that child to have adequate stimulation to develop appropriately. And therefore, a mother that has depression impacts negatively on the development of a child. Next slide, please. So what are the risk factors for postpartum depression? Again, a personal or family history of depression problem, risk factors. Family history, previous history are all biological factors. And then for the pregnant or the woman that has delivered, there are changes in the hormones which are responsible. So during the first and second stages of labor, there's a decrease in progesterone. Then when the placenta too has been expelled, there's a reduction in estrogen. All these affect the neurotransmitters responsible for how the individual feels and even how they think and all that. So their mood and then psychotic symptoms, these are all regulated or impacted by the hormonal changes that happen. And then the difficulties that happen with pregnancy, a lack of a confiding or supporting partner or family members, and all the other social problems that we can think about. Next, please. So we're talking about depression in people with chronic illnesses. It is known that 1/3 about people with chronic illnesses who are hypertension, diabetes, HIV, TB, and all that. So we are actively trying to manage these physical conditions without looking at the mental health aspects. But I want to say that it's very important because these people are prone to having depression, and especially for people who have the very painful chronic illnesses, they are very prone to having, depression. So up to 1/3. So that's about 33 people out of 100 of such people. And we can imagine the enormity of that in primary health care. So there's the need for us to look actively for these ones with depression and manage them. And these would impact on the outcomes of the physical condition as well. Next slide, please. So this is how common depression, the prevalence of depression is with the chronic conditions. So as we can see, in people with tuberculosis, you have almost 50% of them having depression. HIV is that close. For people with cancer, almost 40%. Let's see, hypertension, diabetes, it's about 30%. And then myocardial infarction, about 22%. So this is how common depression is among these populations, and therefore there's the need for us to look actively for depression and manage, because it has an impact on the outcomes of the management that we are given for these physical conditions. Next slide, please. So this is a slide that talks about the fact that we need to have, again, a high index of suspicion for these different populations or subpopulations. For children and adolescents with behavioral problems, for the elderly with dementia-like symptoms, for people with self-harm, alcohol use, or epilepsy, and then people with carer burden, that's people that are taking care of adults or children with, chronic illnesses and other mental, neurological, and substance use disorders. That's the only way we'll be able to pick up the diagnosis of depression in these people. When we see these people, let us look actively for depression, and then so we'll be able to manage or intervene appropriately. So I would end here for Dr. Adwoa Kusi-Kyere to continue with the presentation. Thank you very much.
Thank you so much, Dr. Boadu, for this insightful presentation. I actually am fascinated about how you've been able to kind of break it down to our level of our understanding, let me put it that way. So we really appreciate it. To everyone, I would want to encourage that let's keep our applauses and appreciations coming through the chat box. Let's appreciate her for all that she's taking us through this afternoon. And I would also like to encourage that keep your questions coming. And to Dr. Boadu, if you could kindly go through the chat box, there are some questions that have been posted there already. You could kindly start responding to them even as Dr. Kusi-Kyere starts her presentation. Doctor, over to you as you cemented on our topic for today.
Good afternoon. Can you hear me, please? Okay, so I will continue with suicide risk assessment and identification. Next slide, please. So we will look at suicide risk assessments in the various age groups and subpopulation. We'll start with suicide data. Globally, it's been estimated that about 1 million people die by suicide every year. And that's about one person dying from suicide every 40 seconds. In Ghana, the rates that have been reported, it's about 1,500 per year. But these rates are said to be underreported because there is evidence to show that for every one reported case, there are 4 more that are not reported. And for every one person that is reported to have died from suicide, there are 10 more people attempting. For every one person attempting, there are 10 more people with a plan. And for every one person with a plan, there are 10 more with suicidal thoughts or ideas. And so it brings to fore the fact that with every one reported case of suicide, there are thousands in the spectrum, either contemplating, planning, or having thoughts of taking their lives by suicide. And it is important that when it comes to reporting, especially for the media, reporting is done appropriately because there's this phenomenon called the copycat suicide, where depending on how the reporting is done, whether it is done with too much detail or whether there's so much graphic and painting of the suicide, you can have anybody in the spectrum actually copying the information that are given by the media. So the media often is cautioned against graphically painting the picture of suicide reports. When it comes to the distribution, it's bimodal. It's common for the young and the elderly, so ages 15 to 29 years, and those 65 years and older. Next slide, please. So women tend to attempt suicide more than men, but men die more because they tend to use more lethal methods. Fortunately for us as a country, suicide has been decriminalized, and so we are also changing terminology from saying committing suicide to saying dying by suicide. Although I mentioned the copycat suicide phenomenon, it's important to note that as clinicians, wherever we find ourselves as doctors, as nurses, during your clinical evaluation, you should ask about self-harm and suicide because there is evidence to show that when you do ask, you are actually not putting the idea into people's heads. For most people, when they are going through suicide thoughts and behavior, is very distressing for them. And so asking actually brings some kind of relief to them. What we caution against is for you to, during your inquiry, to suddenly ask whether, for example, somebody wants to kill themselves. If you do that, you tend to scan some of your patients and you might miss many others in the spectrum. It's always a good idea to transition smoothly. So, for example, you can start asking questions about feelings of hopelessness, feelings of worthlessness, helplessness, and then you can go on to ask questions like, do you wish you would go to sleep, for example, and not wake up? Do you have feelings that you are better off dead than alive? And then you can go on to ask about thoughts of taking their own lives. And depending on the responses you get, you probe further. You want to find out the frequency, the intent, and do they have plans in place? Are these plans legal? Have they attempted before? These are all valuable questions. Next slide, please. So when it comes to the risk factors, it's important to state that suicide is extremely complex, difficult to predict as well. For some people, multiple factors might contribute to an increased risk, but sometimes there are few who do not exhibit any of these factors. But many others do have warning signs, which as clinicians or healthcare providers, we must take seriously. The risk factors that are common to all age groups and population is when the person has a history of a mental health disorder. So, for example, they have depression, anxiety, bipolar disorder, schizophrenia, and the others. Or if the person abuses substances, that's also a risk factor. If there's a previous suicidal attempt or access to any kind of lethal means, weapons, poison,
Stop mild depression.
and these days, we are having quite a number of people overdosing on medication they have access to. Next slide, please. So specifically for the various age groups, there are some risk factors to also look out for. This list is not exhaustive. For adolescents, if they've had a personal history of self-harm or suicidal behavior, even in family members or their peers, If they've had exposure to suicidal behavior on the media as well, it's a risk factor for them. Bullying or social isolation, exclusion, for example, which often adolescents face. And when it comes to bullying, it also includes cyberbullying. For adults, you are looking at physical illness or chronic pain, relationship problems or divorce, financial instability. For the elderly, also physical illness or chronic pain when they are bereaved, when they are socially isolated or lonely, or they are beginning to have reduction in their cognitive function. These are all risk factors for them. Next slide, please. So there are warning signs that most people who take their lives by suicide tend to have. There are few who do not exhibit, but it's important to take any kind of warning sign seriously. And depending on where you find yourself, always get the help of a specialized mental health professional. If you don't have any such professional close, it will be important to use the crisis intervention hotlines available to at least get your next step of action. Next slide, please. So these are some of the warning signs. If you find that someone is always talking about death, taking their lives, so you find their conversations about death or killing themselves, you see it in their social media channels, on their WhatsApp statuses, you need to take it seriously. If you find an individual always expressing feelings of hopelessness and helplessness, feelings of being trapped, having unbearable pain, which could be emotional or physical. You find somebody who did not used to use substances, alcohol or drugs, all of a sudden increasing their use of alcohol or drugs, or a very calm, collected individual suddenly acting recklessly or engaging in risky activity. That's also a red flag. It's also a red flag to find somebody who is always sociable, engaging in social activities, suddenly withdrawing from friends and family, sleeping too much or too little, when there is extreme mood swings. So commonly for our patients with bipolar disorder, who tend to have both depressive episodes with either a hypomanic or manic episodes, it's common for them to attempt suicide when they are switching from mania or hypomania to depression. Also, individuals with personality issues who tend to have mood swings also tend to have this warning sign as well. When it comes to individuals, if you find somebody making arrangements for the future, all of a sudden they are putting everything together, giving away their prized possessions, writing their will, sharing property, basically making plans for the future, it's also a warning sign. Next slide, please. So there are several assessments to assess the risk of suicide. And this is one simple one that can be used in the primary health care setting. It's simple, it's an acronym, the sad person scale. So the acronym looks at the risk factors and scores 1 point for every risk factor and uses the total scores to actually decide on the next clinical action. So altogether, we are looking at 10 points. And depending on the number of points a patient scores with these risk factors, we are looking at a low risk when the person is scoring 0 to 2, moderate risk when the person is scoring 3 to 4, high risk when it's 5 to 6, and very high risk when it's 7 to 10. Often with high to very high risk, you are expected to admit the person and start a suicidal watch and management and get the help of mental health professionals. Next slide, please. So we'll look at treatment and prevention for both depression and suicide. Next slide. When it comes to the treatment of depression, there are several interventions that are effective and have been proven by evidence to actually improve the mood of individuals with depression. We have psychosocial interventions, which basically can be used for all our patients with depressive episodes, but it's actually the mainstay for patients with mild depression. From moderate to severe depression, we now think about using medications, antidepressants medication, in combination with psychological therapy, which often is given by a specialized clinical psychologists. There is also the electroconvulsive therapy, which basically involves passing electrical currents through the brain to bring about the chemical changes that is needed to improve mood, often done in a more specialized setting and often done for certain specialized populations and used when most of these other interventions have failed. Next slide, please. So we'll look at some of what we can do with a psychosocial intervention. The good news is that with psychosocial intervention, anyone at all can provide these interventions. You don't necessarily have to be in the specialized mental health setting. It's important that while trying to address psychosocial stresses, you talk to the individual in privacy because the patients feels more safe to discuss their intimate problems. And when you are inquiring, find out from the patients, especially during the time when you are taking the family history and social history, to find out which resources they have available to them, who they turn to when they have concerns, when they are worried or they are in distress. Also find out about abuse and neglect, brainstorm together about solutions, and also assist with ways the patients can cope. Involve family members where appropriate, and if you know of any support group that the patients can be involved in, you can actually encourage them to get involved. Next slide, please. Another way to help with the psychosocial intervention is through the problem-solving techniques. And with this technique, it actually looks at 6 steps in helping the patient to solve the problem. We are not saying that you solve the patient's problem, but you are there to serve as a guide when it comes to solving their problems. So you help the patients identify their problem and to prioritize which problem, and then think through all the possible solutions to the problem. So they are coming up with what available solutions they might have to the problem. They select the most appropriate solution and implement. And if the solution does not work, they could always come back to the basket of other possible solutions and continue the cycle. Next slide, please. So also on the psychosocial intervention, when you are depressed, there's actually the risk of further withdrawing from loved ones, from social activities, which often further worsens the depressive episodes. It's important to give advice to patients that they need to actually engage in social activities like family gatherings, go out with friends, visit neighbors, engage in sports. They could actually go back to an old hobby, find a new one, engage in community activities. If there's a party or a wedding somewhere, they should try to attend some of these activities. It does improve their mental health and mood. Next slide, please. When it comes to children and adolescents, it's important to note that while addressing their psychosocial stresses, you take into cognizance the psychosocial stresses of their parents, because it does affect children as well. So you need to assess their parents' psychosocial stresses and manage them. Remember, we said that maltreatment, exclusion, bullying are all risk factors for depression in this age group. So assess and manage these accordingly. When it comes to children and adolescents as well, they are not separate from their immediate environment or external environments. Oftentimes, they tend to have problems in school. So with addressing their psychosocial stresses, it's important to involve their teachers so they know how to support them in school. It's also important to give education to parents on how they should care for children and adolescents who are having depression. Next slide, please. So with medication, as I mentioned earlier, it's often indicated when it's moderate to severe depression. And there are several medications that can be used. But the first line when it comes to antidepressants medication is the selective serotonin reuptake inhibitors. And commonly in our country, fluoxetine is common in most of the regions nationwide. So that's the first line medication you need to use. Sometimes some people also use the tricyclic antidepressants because that's what they have available, amitriptyline. But you really need to be cautious when you are using amitriptyline or the TCAs, especially when you are dealing with a patient with suicidal thoughts and behavior, because TCAs tend to have a very narrow therapeutic index, which means that if a patient decides to overdose on their medication, it's going to end with fatality. Also be cautious. Try and avoid it in the elderly, those with dementia or cardiovascular disease, because TCA is potentially cardiotoxic and does worsen cognitive impairments. When you are prescribing the medication, fluoxetine, often you start with 20 milligrams. We want you to start at a low dose and titrate up slowly to the requirements of the patient. And when you give medication, do not expect improvements few days after starting medication. So don't stop medication few days thinking that the medication did not work. You really would have to give some time, space, about 4 to 6 weeks before you can actually tell whether the medication has worked or not. And after you have treated the patient is doing well, symptoms have resolved, it's important to continue the medication despite the patient's not showing symptoms 9 to 12 months. And this is important because it prevents recurrence of the depressive episode. When you decide to stop 9 to 12 months after resolution of symptoms, do not stop abruptly, otherwise the patient can risk withdrawal symptoms. You slowly taper down just the same way as you titrated up. And as has been mentioned, when it comes to patients with mild depression, use more psychosocial interventions, what I have mentioned already, in addition to regular advice on regular exercise, having a regular sleep routine, having a good diet, etc. For those who are bereaved, also focus on the psychosocial interventions. Don't just jump into medication. And if there are culturally appropriate mourning rituals, use them as well. Sometimes you can have patients with depressive symptoms, but it's actually due to a medical condition. Conditions like anemia and hypothyroidism could actually predispose patients to depressive symptoms. So if there's a physical cause to the depressive symptoms, you must rule it out and treat that underlying physical cause. Also, focus more on psychosocial interventions for children, pregnant women, breastfeeding mothers. But if their depressive episode is severe enough to require medication, we would ask you to involve specialized mental health professionals. Next slide, please. For suicide, is actually a medical emergency, especially for those with high to very high risk. And so in the immediate emergency period, when it comes to treatment, we have what we call the crisis intervention, where you are using the hotlines. So for us in Ghana, we have the National Suicide Prevention Line that can be used. You could also use the emergency lines, which can get you to the security officers or ambulance service. They will give important information on your next steps. But remember, depending on where you find yourself, if the patient has a high risk, a high or very high risk of suicide, you need to admit this patient and do what we call a suicide watch. If you have the privilege of being in Accra or in the central region and you are close to a psychiatric hospital, get into these psychiatric hospitals immediately for help. Also for suicide, often for patients with very low risk who are being managed on an outpatient basis, we have what we call the suicide contracts, which is a very useful tool to use. Basically, the patient goes into an agreement with a healthcare provider. All you need is a paper and a pen. So the patient actually agrees that if at any point in time they want to take their lives, they are going to contact the healthcare provider or a significant other who can find help for them. And so they write this agreement on the paper, they sign, the healthcare provider signs, and there's also a witness who also countersigns. It's actually a useful tool. For the short to medium or long term, psychological therapy is very important. It helps them to cope with their suicidal thoughts and behavior. It also helps in addressing underlying issues. Medications are also important because we get to use that to manage underlying mental illness that has predisposed the patient to suicidality. And we have what we call the safety planning, where basically you develop a safety plan for the patients to help them with their suicidal thoughts and behavior. And it includes identifying triggers, coping strategies, and sources of support. Next slide, please.
Okay, so Dr. Kusi-Kyere, please, could we kindly be wrapping up in maybe in the next 4 minutes, please?
Yes,
please. Thank you.
So this is the National Suicide Prevention Helpline. Next slide, please. So it's also important to state when it comes to the treatment of depression and patients with suicidality. Remember, we said when it comes to risk factors, there could be biological, psychological, and social risk factors, which are individualized. So the interventions really have to be tailored to the patients. Next slide. So to conclude, we have talked about depression and suicide across the various age groups and subpopulations. We have looked at various risk factors among this group. We have looked at 2 simple assessment tools that can help with the identification and assessment of patients with depression and suicide. And it's important to note that always add your clinical evaluation to these assessment tools. It's important because it does help to identify the risk of the patients for further assessments, management, and referral. Also, we have looked at various interventions for depression, both pharmacological and non-pharmacological interventions. Next slide. So finally, we want to buttress the fact that mental health is as important as physical health. When you are dealing with patients with depression and suicide, it's important to actively listen to them, be empathetic, be non-judgmental. And let's all take note of the risk factors we have mentioned in this presentation to actively screen for depression and suicide to all patients who attend primary health care. Thank you very much.
Thank you very much, Dr. Kusi-Kyere. I think I can confidently say that, again, this was rich knowledge being shared. And I can also confidently say, and I'm sure my co-facilitator would give me thumbs up, to say that not some, learning has happened. But the good news is that there is still more to come in our from the discussions of our case presentation, which will be happening by